Later, yes. Thank you very much, Spira. Well, so maybe that's a question for the for the end of the session when we have to debate, maybe time for debate. So the next talk is from Professor Giacomo Pongiglione. I hope I pronounce it right, from Rome. Yes. And maybe he gives some answers to Mira's dilemma, which is putting multimodal data together and then modeling some disease to make some decisions, basically, at the end.
Okay. Oh, yes.
Okay, leave it here.
Oh, it works. But okay. Okay, first of all, let me join the previous speakers to thank Professor Loeffler and the organizing committee for inviting me here at this prestigious meeting. So the most difficult part in the doctor-patient relationship is not diagnosis, is not treatment, is decide what's the best option for the patient that is right in front of us. Normally, we refer to epidemiology. So in other words, we check what's the outcome of a certain treatment in a selected population of patients affected by the same disease. But obviously, this is not personalized medicine because we cannot predict what will happen to the patient that is right in front of us. So if we want to be a bit more specific, we try to enlarge our database to have a more meaningful search. And that's what we did in our previous studies, merging our database with London and Berlin. So the idea is that if we virtually delocalize our patients, we can create a more homogeneous subgroups of patients so that a new patient that arrives can be compared with a more similar subgroup of patients. That's what also did it in our own institution, because we have a big institution that is based on two main sites. One is in Rome, another is in Sicily. But even the site in Rome has several locations because, for instance, outpatients are located in downtown Rome. Electrophysiology and rehab medicine are based in another place. And each hub also is connected with several peripheral hospitals. So we have, we generate more or less more than 20 terabytes of data per year. So we are dealing with large amount of data that are distributed. For dealing with that, we need an infrastructure that allowed us to interconnect all the sites. But on top of it, we need a platform that allowed us to roam, to search for all these patients wherever they were. Then we need the software to treat this data, and eventually, finally, all these data were used to create models. I will see how we did. So first of all, but since we merged our data also with outside institutions, we needed also an additional feature, this is the anonymization of our problems. So in other words, all our patients are anonymized and merged with London and Berlin as well. But as I said, the patients we are interested in are not only located in one institution, but also in the same institution. They may be located in several locations, and the data within the same location can be stored in different servers, because, for instance, the data from MRI are stored in the RIS radiology information system, data from the cath lab are in the cardiology server, data from echography in another server, and so forth. So if you want to make a search, combine different variables, we had to be able to roam through all of these possible servers. So we had this application is provided by Nubila. This is a spin-off of the CERN in Geneva. So it gave us this possibility. The problem with medical data is that they are heterogeneous, distributed, as I was saying, very complex. There's high dimensionality, especially if you incorporate genomics and proteomics. There is a lack of standardization, and this is not just because someone is using millimeters and someone else is using inches, but the problem is that the same structure, for instance, the diameter of a valve measured with one tool, for instance, with echocardiography, is different from the same structure measured with angiography. So we need to have a standardization also of our measurements. Then our data change, as well as change our knowledge, because there is a temporal evolution. Very often data are not characterized mathematically. Often we write dilated ventricle. Dilated doesn't mean much. You know, doctors are anechoic. I'm a clinician, so I can say. Data are always missing, inconsistent, noisy. Sometimes the interpretation results is ambiguous, and then there are concerns of data ownership, privacy, and security. So if we add genetics then it becomes a nightmare, because as I've heard before, the same gene abnormality may be related to different phenotypes, but the same phenotype may be related to different gene abnormalities. And not only that, the gene expression, different gene expression can create a different pattern of the development of the disease, completely different pattern. So among all this big amount of information, we have to define, to identify what are the really characteristic features of each disease. So we know we have a lot of features, but what are the real ones? So for instance, we have two groups of patients. One is John, Charlie, and Steve. The other one is Sylvia, Camille, and Martha. So you might say, well, boys and girls. Or you might say Americans and Italians. Or is this one the distinguished features? We don't know. We simply don't know. So if we were in electronics, we might say that the noise to signal ratio is very bad. In other words, we have a lot of background noise or information that prevents us to find what are the real important characteristics. In other words, we may have already the information that can give us answers, but it's difficult for us to pick up the real information. Then, if the information, if the dimensions, if these features were two, well, we are quite good in analyzing pair comparison, etc. The problem is that, in reality, the information are many, and they should be analyzed jointly. And therefore, it's a big problem. We have a tsunami of information. So if the information are in the thousands, the real important information, but if there were just 7, like the 7 notes, think how many possible combinations you have from the Beatles to Mozart. If there were 30, a cloud of 1 billion computers, 1 billion times faster than the fastest existing computer today, working for 1 billion years in 1 billion planets, won't even scratch the surface of the problem, as my preceding speaker just said. Exactly, I agree entirely. So we have to change totally the system, our approach. And we have to use information technology. So on top of the infrastructure, I say we have the middleware. It was the cloud system that allowed us to go through all the data wherever they were stored. Then we have several softwares. One is artificial intelligence software provided by University of Athens. It's called Aetion. Aetion means a Greek word that means because. And this is the base for the word etiology. Okay, what does it do for us? First of all, it does data curation. Data curation means that it finds out missing data, inconsistent data, outliers, etc. And it's kind of a bottom-up process. But not only that, it also does a top-down, in other words, incorporating external knowledge. Let me make an example. If I give a patient beta blockers, they are supposed to slow down heart rate. If the heart rate doesn't slow down, but it increases, but still within normal range, a bottom-up data curation wouldn't show up, wouldn't highlight this patient because it's still within normal range, but it's not what is expected. So a top-down analysis might just say, just show to the clinician that something might be wrong. And then he found inferences. So in other words, this software can find what are the inferences between different variables, and therefore identifying what variables are really relevant in this particular case. Once we have found that, then we use this software that's provided by Siemens Corporate Research, based in Princeton. We call it Case Reasoner. It's a similarity search. With this, we can use whatever variable we want, wherever they are stored, and we can cluster our patients and create groups according to the variables we have selected, again, wherever they are located. We can create as many variables we want, as many clusters we want, but central to this analysis is the concept of distance. Initially, we let our technical components to define what distance was. They used what's so-called the Euclidean distance. Wrong, was the wrong approach. Distance is a totally medical concept because there are variables that can vary a lot, variables that can vary very, very little, and they can vary also according to the population, to the age, and to the pathology. So distance is a medical concept. And once we did that, things had a much better outcome. And so we can create clusters. Let's show you just a couple of clusters. Yes, so we can cluster that. We can resize the number of clusters the way we want. But we can also create clusters not only according to the variables, but also according to the morphology, to the mesh. Now, was provided we have done a mesh. In this case, for instance, we created the mesh of the right ventricular outflow tract, and therefore we could also cluster our patients according to the shape of the morphology of, in this case, of the right ventricle. And but the analysis was the same. Also, we needed to go beyond the classic pair comparison, and this was using the kernel. What is a kernel? Suppose that we have all our red and blue dots in the plane, and we cannot distinguish between of them. You cannot separate the two populations. But if we add one dimension to our plane, we might find out that all the blue dots are on top, all the red dots are on the bottom, and therefore it's not a line, but it's a plane that divides our population. Since in mathematics the number of dimensions is infinite, we can create a multidimensional virtual universe in which our population can be analyzed. The last step in our analysis is to create, so at this point we have created a statistical model of our patient, but then we want to create a computer model of the patient. How do we do that? Practically the first steps are the same. From the initial data, we make a selection of the data, of course. We pre-process, we transform the data, we do our data mining. From data mining, we create the ontology, the model. What is the model? What is the ontology? If someone has some recollections of high school studies in Plato philosophy, the model, a dog was, could be big or small, white or black, but a dog was a dog because he had the idea, the concept, we embedded the idea of the dog. So we try to do the same. We create a model of the disease. What is the ontology? Is the domain of knowledge, for instance, in our case, in our first case, post-op tetralogy of Fallot, represented by facts, pulmonary regurgitation, right ventricular dilatation, contractility, right ventricular output, structured by, and there are logical connections. In other words, the more the pulmonary regurgitation, the larger right ventricular volume, the lower the right ventricular contractility, the lower right ventricular output. Structured by formal rules, by equations that can be interpreted and used by computer. So for each patient, from any possible data source, clinical imaging, et cetera, we create all the vectors, and the sum of these vectors is the integrated feature, this is the ontology. In other words, the ontology, the creation of a mathematical model of the disease integrating environmental, familial, genetic, clinical data in imaging. So with the first project, the Healthy Child project, we created the model of a dilated right ventricle. So from a genetic model, it was created by in Riyadh, is the French Research Center, we personalize it just overimposing the data of an actual patient. So we created the model of the patient, of our real patient. As in this model, you could see that was the apical portion, the blue one, this blue one, that is not contractile. So we did our simulations, and we asked our virtual surgeon to perform a valve interposition and the removal of the non-contractile portion. And the computer, and then we made a comparison, and the computer predicted that in this way, not only the right ventricular function was improved, but also left ventricular function would improve. And that was exactly happened to our patient. In the following project, we created the model of ascending aorta. You know that in several cases, for instance, in a very common disease, as bicuspid aortic valve, the ascending aorta is very dilated. If it's too dilated, the patient can have dissection and possibly also death. We have criteria to decide if the aorta is too large, and therefore the patient needs surgery. The problem is that with the current criteria, we miss 30 to 40% of dissections. So again, we created the model, and we tried to incorporate all the analysis we had. For instance, this is a velocity all the velocity vectors of the aorta, in the ascending aorta. We added the vorticity, in other words, because the spin analysis is also a part of energy delivery on the wall. If you see, for instance, in the right portion here is how vorticity here generates a force on the wall. So we're combining everything. We analyze the velocity of the jet, the width of the jet, the angle of impact, etc. So we arrived to define what was the wall shear stress. The wall shear stress, it was the additional pressure that is exerted on the aortic wall. And you see, for instance, in the case on this side, we have 2 pointed risk. This is a very useful information for the surgeon. From there, that's what we are doing now. We want to move from wall shear stress to wall stress. There is a real indication of risk if you combine it with the modulus. I'm finished. With the last project and deep degree, we are elaborating the model of the left ventricle. So practically, little by little, we combine the whole heart. So finally, integrating clinical data, imaging, genetic data through the cloud system. We have integrated data, integrate this in modeling, and that's the base for decision support system and knowledge discovery. So ontology-based cloud technologies are a new multidimensional information environment for collaborative data handling, for a personalized decision-making, and the digital patient is the virtual representation of the integration of the computer models of the different organs, because from the model of the heart, you can combine all the different models and eventually get to the virtual patient. And it's a new technological level of biomedical research. Thank you very much. Was I on time? Did I stay on time?
Almost.
Great.
It's okay. Any questions? I think it was simply too impressive.
Speechless. No.
No question I want to ask. 2 questions. First of all, very nice. And
Thank
this
you.
is a solution. But I just wanted to ask, you know, in parallel, like the various data mining is a big name.
Yeah.
But like I have a data mining, you have a data mining, but each one is working differently. So are you analyzing each, you know, cloud of data, like the imaging separately and then combine it with the other and so on? That's one question. And second, how on which basis are you doing the prediction? For example, in order to overcome that, we used logic, you know, rather than mathematics in the beginning and then mathematics and then coming back. What are you doing?
Well, actually, we are moving in parallel. In other words, the statistical model is used for validating the computer model and vice versa. At present, we are trying to find what's the best. We don't know. In other words, the difference between a computer model generated by the engineer and our computer model is complete, because an engineer make an engine, make whatever, based on science that he knows. He has created a model. We have created a model of an organ of which we know very little. Okay, so our model, by definition, is very imprecise. Therefore, we need to validate it. How do we do that? With the statistical analysis, comparing with a similar group of patients and checking each other. That is the way we are proceeding. Thank you.
Anything else?